So the order of tonight's speakers has got nothing to do with importance and everything to do with the likelihood that the speaker will still be awake by the time it's their turn. So that's why I'm going first. Look, for those of you who've experienced the worst of this thing, please accept my admiration for your work and my best wishes that things will improve. Now, where are my slides? There we go. Oops. Great. Thank you. So, look, epidemiologists, health managers, health bureaucrats, politicians, they're not clinicians. They're not used to moving fast or to dealing with rapid deterioration or uncertainty in their day-to-day lives. They tend to negotiate their way very carefully and very slowly in fixed systems. So in situations like this, they're going to struggle and they're going to look for quick answers, and they're going to be advised initially to turn to safe and very off-the-shelf solutions. The problem with that is the pandemics are relatively infrequent and rare, and so they're often offered ideas that are hundreds of years old. And I guess we've all seen that that has happened again to a certain extent in 2020 with this pandemic. I guess our job is that because hospital in the home is a relatively new concept, we have to convince the system that we have an alternative to offer, and in the COVID, as a COVID response. And as it happens, hospital in the home has a lot to offer. It's got the ability to provide clinical hospital level supervision and monitoring. It can investigate people effectively away from the hospital, and it can offer treatments like intravenous antibiotics, intravenous antivirals, intravenous fluids, some special oral medications that may require monitoring, and even some oxygen. And these are all things that hospital in the home have done before, and they're all things that, as it happens, have a contribution to make during a pandemic like this. So from the health system's point of view at the moment, there's a great need for increased capacity. And I guess a lot of that focus is on intensive care, and that's reasonable, but there's also a great need for increased capacity in a non-ICU setting. And essentially that's for COVID positive or COVID suspect patients who have mild to moderate disease. They may be on the upward trend of severity or after an admission in hospital. And there's also the need for the acute treatment of acute medical treatment of patients who are non-COVID in hospital. And there's also one other factor I think we're finding, which is that patients who are aware, or people who are aware that they're at high risk of severe COVID disease, that is people who have cancer or who are immunosuppressed or who are elderly, are actively avoiding hospitals and looking for alternatives if they're going to have acute treatment in the current situation. So I guess in a scenario where acute bed capacity is what's required, it's very fortunate that from a health system point of view, the primary thing that hospital in the home does is that it builds beds. And so the current platforms that we have are scalable, they can grow quickly, they're already integrated into hospital systems, so the flow of patients and communication and investigations between hospital in the home and hospitals are already established and quite flexible. And that sets us apart from ideas where people want to either recommission old hospitals or to commission hotels or, you know, basketball courts full of people on stretchers, where there's a great danger in bringing those and a great inefficiency in bringing those models into fruition. Capacity growth for us is relatively cost effective, again, because we don't have bricks and mortar. And the kind of technologies we're used to using are the kind of technologies that offer the best solution in terms of treating people at a distance at home. So I've seen the impact of COVID on system responses to hospital in the home, and I guess I have some observations to make both in the pros and the cons. In terms of the pros, we've certainly seen that hospital in the home has had significantly increased access to high-level decision makers and high-level decision-making processes because they're looking for solutions. And if we say we have something to offer, then we're being listened to. Secondly, cost is less important than solutions. So business cases are less important than having something to contribute. Thirdly, the people who would traditionally not be supporters of hospital in the home are distracted. They're either not there, they're too busy, or genuinely they see that they need help. And if we can offer help, then they're willing to accept it. And I guess part of what I'm experiencing is a recognition that hospital in the home is part of the team. We're inside the tent, we're inside the castle wall finally, and people are starting to acknowledge us more significantly than I've ever seen before, to be honest. And finally, when the health system needs to communicate to the community that they're doing something, and hospital in the home is part of that something, then there's a strong message coming out in terms of supporting hospital in the home and its role. But there are pitfalls as well, and I've listed some of them. Like the rest of the system, we have access issues to staff and to equipment. I guess the point I would make is that it's probably a bad time if you're a hospital in the home to try something that you've never tried before. So if you haven't looked after people with pneumonia in residential aged care facilities, it might be a bad time to start learning if you're overwhelmed. And finally, there are going to be people coming out of the woodwork who have suddenly think they've conceived of a concept of non-hospital-based pandemic care, and will essentially be trying to tell people that they can do it better than we can. And I think that that's a problem that we need to be aware of and to counter very quickly. So finally, I just want to give you an example of what can be achieved in terms of a health system impact for hospital in the home. This is the official Australian COVID data site, www.covid19data.com. It's where all Australian data is collated and on a daily basis in real time, therefore. And so this is from the state of New South Wales, which is not my state. And this is the section that looks at hospital utilisation. So you can see that in the grey, you have ventilated patients. In the black, you have ventilated patients. In the grey, you have ICU patients. In the green, you have hospitalised patients. But I was very, very impressed to see a section that was light grey that says total in care, including hospital in the home. So you have a state, which is the equivalent of a province in other countries perhaps, where there's been a health system recognition of the role of hospital in the home. It's been counted, it's been included, and it's formed part of the message to the community, both the medical community and the non-medical community, that this is part of what we're doing in response to COVID. It's very, very encouraging, and I was very pleased to see it. That's my very short observations on our role in terms of health system for now. So Itamar, I'll hand back to you if that's okay.
Thank you, Michael. It's very insightful. Thanks a lot. Our next